Hi everyone, welcome back. Today I'm going to be talking to Ollie Burton about the challenges as we have experienced them in surgical training. These are all the things that I kind of wished I'd known before I went into surgery or even before I'd gone to medical school, to be honest. And so these are mine and Ollie's kind of lived experience. We're going to do a deep dive into issues like the bottlenecks that we're experiencing and things like skills creep and ACPs. Joining me today is Ollie Burton. I'm sure you'll have seen his YouTube or his Instagram. I use it all the time when I need to find out something medical related. So Ollie is currently on a fellowship. He's working for the National Medical Director, and before that he was clinical research fellow in neurosurgery, and he's been non-clinical. So I've been clinical for a long time. He's non-clinical. So I'm really keen to find out exactly how it's been non-clinical.
So how's that going, Ollie?
It's very different. For those who haven't spent any time uh, outside a full-time facing clinical role, and I think that will probably be most people, like we have this understanding of what a medical career looks like, which is probably pretty flawed. But you imagine that someone goes to medical school and then they become a foundation doctor and then they apply for training and then they become a consultant and then they do whatever. But I think we certainly both know that most medical careers probably don't look like that. And lots of people do lots of different and interesting and cool things. So my current job is a lot of data science and data communication and management, I guess, which is not really anything like any clinical role I've ever done. And it's still stressful, but in a completely different way to clinical medicine. So it's certainly been a great experience looking at national audit data thus far. And I've got through until next summer of this, really enjoying it. But it's challenging just in a very different way.
So, what we're going to be talking about today is some of the challenges as we see it in being what we call now a resident doctor. And we're going to be unpicking some of the ones I think that Ollie and I have personal kind of experience of, because obviously we're kind of junior in our careers. We've finished our foundation years. We're at the point where we're trying to kind of lock down into those middle grade roles, which are almost the runway to take you straight to being a consultant. And in some ways, I don't know where you are watching this journey. Maybe you're a medical student, maybe you're pre-med, or maybe you're like us, you're trying to get into training. It's really not straightforward, is it, Ollie? Would you say, if you're honest, it's a lot less straightforward than you thought it would be as maybe a fifth year med student? Or were you well
Yeah.
prepared? Yeah.
Well, 100%. I think it's one of those processes where you look at how complicated it is, and then you're like, how does anything actually you work? How are there senior doctors anywhere?
Yeah. Oh my God, yeah.
It's so disjointed in a sense, and so many opportunities to stumble. And
Yeah.
it's worse, I would think, with your because we're in very different specialty areas, right? And at least I'm trying to apply for neurosurgery training, and that's run through. So
Yes.
what that means for people who don't know is it's a bit like how an American residency program works, in that you apply once very early in your career, straight after foundation if you want to. And then once you get a job, you are on the path, on the conveyor belt for very many years until you become a consultant or a senior practicing doctor. Um, Whereas for you, it is not like that.
Nope. And I'm very envious. So, for people who don't know, I want to do plastic surgery. So, I'm a core surgical trainee. So, my journey has been foundation, straight to core surgical training, of which I had to work very hard to be. I was doing pediatric surgery, so I got my first choice, but I really broke my back getting that job. But then for me, that's a 2 year program full time. I'm doing it less than full time. And then I have to reapply. So I'm having to do twice what Ollie is doing. Although I think neurosurgery is more competitive than plastic surgery.
It's hard, isn't it? Because I guess that there are fewer people who are eligible for plastics at ST3 because anyone who has completed foundation can apply for neurosurgery. There's no stipulation of experience. So I guess I'm sure in some senses it's more competitive, but also I guess the pool of people that can even apply to plastics is much smaller because
Yeah,
you would
you have to have
finish
done CS.
university.
You have to have done CS2.
Yeah.
So the
So I don't know.
reason, so I guess to summarize, in some ways, we're both in exactly the same place in a surgical career. So it's different types of surgery, to be fair, but we're still trying to get these middle grade roles. And the reason that I wanted to talk to Ollie about this, because for me, Ollie's like Mr. Medical News Zeitgeist. Like, whenever like, because I'm really lazy, whenever there's an issue that comes up in our field, like, the BMA are chatting something, and I don't trust them. So I know that Ollie will have done a deep dive on this. And so I think, Ollie, your channel and your Instagram posts, there's a lot of, people doing what we do in terms of, like medical vlogging. I think yours comes the closest to journalism. Um, yeah, so that's what I think. So what I wanted to do is what I kind of wanted for us in the course of this video to kind of work through some of the things that are making it really difficult for two hardworking, both of you and I are hardworking. We've been focused. We've been intelligent about how we've strategized, how we've used our time. We've collected the things we need to collect. And yet we are still struggling to get jobs. So one of the things that I always tell people who are not medical is I always say, oh, I'm going to be unemployed next year. And they go, but you're a doctor. We're crying out for doctors in the NHS. And I'm like, no one can get a job. And so there's, for people who aren't in our position, who are maybe medical students or even foundation doctors that haven't yet started the journey that we're on, there's a bit of conflict there, isn't there? Because we don't have enough we don't have enough doctors in the UK. And yet, people like you and I can't get jobs. So why is that, Ollie?
That is all to do with the simplest way that I've found to describe it is a maldistribution problem. That is to say that depending on your perspective, we may have enough doctors for what we want to use them for, but they're not in the right place.
Yeah.
That is to say that, and this is just a sort of applicant to medicine or medical school kind of level. If you imagine the entire medical workforce that is made up of doctors like me, who are at the very start, very junior, and you have doctors at the top, the consultants, the bosses, the experts in doing what they do in GP or surgery or whatever. And you have people in the middle, those who are training, they're in a specialty of
Where
some
we
kind.
want to.
Yeah, exactly, where we're trying to get to. So you have this progression from junior to senior. And those people do different kinds of work. So in neurosurgery, for example, I can do things that are relatively very basic. But obviously they're complicated and you need to be a doctor, but they're things that a consultant is not doing that I might be doing. So seeing new patients, examining, doing lots of paperwork, etc. In that middle bit, I would be learning to become a surgeon and becoming a better surgeon, eventually to become independent and leading a surgical team at the top. Now, at the bottom end, and this is coming back to your why people can't get jobs problem, is that we're actually pretty saturated at the bottom end because there is a mismatch between the numbers of people that are leaving medical school and joining the foundation program and the numbers of graduate training places to get onto that middle tier that are available. And this is when we say bottleneck, this is what we mean. So you have loads of people at the bottom, relatively, competing for a smaller number of places to get onto that middle tier. And then at the top of that middle tier, there is another bottleneck like this for a smaller number of senior posts. And this is complicated and challenging because in a hierarchical workforce like medicine is, this to some degree is actually what you need. You need loads of people on the ground doing all of this stuff, and you actually need a very small number of people at the top to lead all of these teams because every team only has one leader and they are in post for a long time. And so the question is how you control that middle tier. You need enough people to do the work that only that middle tier can do. And this is usually going to be registrars. But you need a much smaller number of people than that to be the leaders. And this is the problem that no one has figured out how to solve yet.
So is this a funding issue?
Partially, but not completely. So the figure that I've been told as a rough guesstimate is that a consultant costs the NHS about £5 million over the course of their career as a consultant.
I can't believe that.
Well, I don't even know whether I think that's a lot or not. I think that assumes a 30-year working career.
Mm.
And 5 million for an NHS consultant, and that includes everything, like their entire onboarding costs, the expected indemnity, like everything that you need to have a consultant doing what they're doing. And to be honest, by standards of other countries, that may not be a lot. But because that number is a big number, the government, understandably, the Treasury, who makes all spending decisions, will want to limit the number of consultants that they have because they're expensive, just like any expensive resource that you need to run a high quality system. So they're a limited resource. That means that the government will want to limit the number of consultants that you have, because if you have too many, it becomes really expensive. So this is the first, I think, important thing to understand, is that we actually know for virtually all specialties exactly how many consultants we need at any given time in any specialty. Every Royal College does workforce projections based on population demand. And demand is going up and up and up everywhere, basically. But the government has not been willing to recruit consultants in the amount that we need, and we are behind in virtually all areas, and that is a spending problem. If the will is not there to fund
those places.
Exactly.
And obviously, it takes 10 years. So when you start to increase that funding, it can take years for some. So if they created a consultant post for me, ideally, it would still take me, especially because I'm less than full time, a decade to get there. So this is like a long-term fix, is on medium term, not long term.
Yeah. And basically the only thing you could do is pull consultants or senior decision makers from somewhere else. So either from abroad, from another country's medical system, which the NHS does a lot.
But that doesn't help us, does it? For those of us.
It doesn't.
So, I think this is part of the issue, isn't it? And so would you say, Ollie, for our generation, is this a problem? Because I would imagine this bottleneck has always existed to a degree.
Yes.
Is this much worse, though, for people of our generation than people who were perhaps in our roles a decade ago?
My genuine, honest read is that it's pretty cyclical. I think my understanding of the problem, and this is taking into account all of the major reforms to training that have happened over the last kind of 20, 25 years, it's cyclical. It's boom and bust essentially. So pre-Kalman, and I'm not going to go into it, but the the Kalman reforms, it was very, very difficult for people to progress from senior registrar to consultant. So there was a massive consultant bottleneck. And people were stuck essentially as senior registrars for years and years and years. The most recent major training reform was modernizing medical careers, which was in the early 2000s, sort of mid 2000s. And what that tried to do was to get as many people to consultant level as quickly as possible. And that was when we saw the introduction of essentially the training schemes that we have today. So foundation, core, or whatever, higher specialty training, and then consultancy, CCT. And what this tried to do was it tried to solve the problem, what's called the lost tribe of SHOs, people who developed loads of experience at the junior level, but never managed to make it into middle grades or senior training. And it tried to get everyone on this conveyor belt to be like, we don't have enough senior decision makers. We need people to finish foundation and then streamline onto a program that's going to make them a consultant, which is a great idea. But then it was never funded or executed properly. So you end up with this half-working thing where we have the same problem. SHOs now can't get into training. So I think the problem is still there, but I think the problem looks different for our generation, perhaps, where the bottleneck is in a different place. And part of that, I guess, is the question that you have to ask yourself if you were going to design a system. Where do you want the bottleneck to be? Do you want it to be at the training program level, where you say, if you can make it onto the training program, you're basically going to become a consultant one day, but this is where the bottleneck is? Or do you put the bottleneck somewhere else in the system? Do you put it in between core surgical training and plastics, say? Or do you put it senior registrar to becoming a consultant? I think it's just moved, is the answer.
So one of the things that I find for me, which has been a little bit soul destroying, is that when I kind of decided to do surgery, because I fell in love with surgery, I think probably as a senior medical student, I think,
Right.
certainly before F1. And, I kind of did my research, and it was like, ST8, 2 foundation years, do it less than full time. I can do that. That's fine.
Yeah.
I'm on board with that. But then what's happened since then is that certainly in plastics, people are, and these are quality registrars, are spending 3 years. I think that's, I've met many people who are spending 3 years between graduating core surgical training, having done 18 months in plastics.
Yeah.
It's still taking them 3 years to get onto a plastic surgery training number. And this is not unique to plastic surgery, because I hear people saying, well, plastics, this is not just, limited to plastics. I know people in gen surg who are having to take, clinical teaching fellow years. And, I think in medicine, this is happening as well.
Yeah.
And I certainly remember when I qualified as an F1, F2, which was around 2018, a lot of consultants were a little bit withering about people taking F3, F4 years. They were, you should be going straight through. But actually, I mean, would you say it's become the norm to take an F3, F4, either through burnout or through not being able to progress to core surgical training, to IMT, to ST1?
Yeah. Or whether it's the norm for an individual person is difficult to say, but for a cohort, would you expect a very significant number to do that? Yeah, sure. I think there are different reasons. And this F3 phenomenon, this thing that you're describing, is not entirely understood as a phenomenon in that we can obviously measure how many people are doing them. We roughly know that, and then we know that some percentage will come back into training. Some people will do an F4. I'm doing an F4. And how much of it is people simply want a break from doing medical school and then doing foundation and being tired and wanting to do something else? Or is it people wanting to become more competitive for a specialty application the next year, or to locum and earn money because actually what they need is a house deposit? I think it's very fair to say that lots of people will do these F3 years and F4 years or whatever. Some of that will be related to pressure with training and with the workforce. Some of it will not be. Some of it will just be a reflection of probably the economic status of the time. And some of it will just be people wanting a break, and that maybe doesn't have anything to do with training. All of these things are valid. But for some specialties, so neurosurgery, for example, it's very rare to get into specialty training without having done your F3 to get more experience as an SHO. As in only probably 1 or 2 people a year manage to get in from F2 out of maybe 20 training places or whatever that there are. So is it common? Yes. Is it entirely understood? No. Should you maybe still do one if you want to do one? Sure.
So when I kind of had my first thought process about Ollie and I having this chat, I thought about this because I was thinking about when I obviously, I'm a very prepared, organized person. So before I went to med school, I wanted to make sure that I made a balanced decision. Did I know what being a doctor entailed? And this is something that everyone kind of thinks about because we know that this is what the medical schools want you to think about. And so when I advise people about how to get into medical school, this is the thing that I say. I say, go and shadow a junior doctor, ask them the questions. And the questions that I asked myself all the way back in those days, which was a long time ago now, were things like, can I cope with the sad of, patients dying? Can I cope with the emotional impact of being a doctor? Which is almost never an issue for me because, I'm a surgeon. So most of our patients are pretty healthy anyway. Rarely have I been around patients.
Nice for some.
Rarely have I been around patients who are critically unwell or dying. It's not at my day to day. Even if we have patients who have got cancer, you're not seeing them at the part of their journey when they're discovering the cancer or potentially dying. You might see them in the middle to do a procedure, and people are usually fairly upbeat. So that's not really been a concern. And the other thing was the long shifts. And actually, I don't really find that too much of an issue. But, Ollie, you were talking a moment ago about people leaving and taking a year out because of the pressures of training. So actually, what I really wish that I had talked to people about when I was a medical student were the things that we're talking about in this video. So the pressures of training, the ability to proceed, because let's be real, Ollie, you are a fairly outstanding candidate, aren't you? You are not, some guy who kind of wandered through foundation training, thought, okay, I might do neurosurgery. I'll kind of throw, a dart at it. You've been planning for this for a while. You've got a really strong research base, and you're not kind of, a standard candidate, I would say. And yet, if a person like you is still not going, being that one that goes straight through, that says a lot to me about how easy it is to get into these programs. And so my question for you is, if you could go back and talk to, tiny Ollie, and you were at that point kind of wanting to ask the questions about what this job is going to be like, what are the cons of medicine? What would you have wanted to know all those years ago?
I think the only I do want to push back on something very slightly, which is that it's just a thing about specialties. For neurosurgery, I'm probably a fairly typical candidate, as in I wouldn't be I think compared to most applicants to most specialties on paper, I've got a lot probably going on, but you I think you should set your expectations or your standards by what the people you're competing with are doing.
Yeah, I
So
mean, it's definitely true.
yeah, so the way that I would advise people to think about it is that certainly by the time you get to interview, you're essentially competing with loads of copies of yourself,
It's true.
and people are the people you're competing against are probably at a very similar level to you, if not better. So that's how you should sort of approach it. But
I don't even think that, to be honest, Ollie, about certainly in plastic surgery, I'm not competing with people like myself. I'm competing with people that have had a trust grade registrar job for 3 years.
yeah, yeah.
So for me, I feel like I'm very, down, this is good.
Bottom end. Yeah. What would I have wanted to know as tiny Ollie? I think something that I just really did not understand and was maybe naive about it, but equally, how would you not be? Is that if you want to do anything in medicine, and I'm sure you feel the same way, if you just accept the statement, I exist and I am a doctor, and that's one thing that's kind of your baseline. If you then want to do literally anything other than that, so you want to join a particular specialty, or you want to do research, or you want to do something where you have agency and choice, you have to work so hard to make any movement. It's like walking through treacle in whatever direction it is you want to go in. So if you simply having control over your life and stability and is way harder than you would think. And if I say I want to be a GP at a time when the country is crying out for GPs, no one can see one. There's a massive shortage of them. It is still going to be very hard for you to become a GP, especially in an area you want to be in. If you want to be a plastic surgeon, again, there are probably not enough plastic surgeons. There's probably a lot of demand, waiting lists, and all of this. It is still like mind-numbingly difficult for
Yeah.
anyone to do that. And I think what I didn't understand is that this mismatch between what the population needs and what what it gets or what people are actually doing, it's basically doctors themselves that are holding all of the weight and the burden, because there's massive neurosurgery waiting lists, for example, for something like back pain, leg pain. It People don't become neurosurgeons without essentially destroying themselves
Yeah.
over the course of not just getting in, which is the very first step, but the entire training program and the career of not sleeping and never resting and doing all of this research and never taking days off and doing 24-hour shifts and all of this stuff that a functioning system would not necessarily require people to do. There are basically loads of points at which the system can fail. And in order to stop it failing, it's actually doctors that are like holding all of this stuff up through various forms of self-sacrifice and doing things that people would or should not be expected to do. If I say, Lauren-Jane, it's Saturday tomorrow. There is a surgical list tomorrow. I know it's your day off. I know you've got other things that you would rather be doing, but you need to be at this list. Otherwise, you're not going to get enough experience. So, you know, take it or leave it, isn't it?
Absolutely. And I'd be there. And I think what you said was so apt about having to destroy yourself. And I mean, I think a lot of us know, I know that I can be a plastic surgery consultant. I'm capable of that. But the question is that I'm asking myself at the moment, how much do I want to sacrifice to do that?
Exactly.
And at the
Yeah.
moment, the system is designed to break you. And I think one of the things that you kind of said was around, you said you're talking about it having to destroy you, and that I think when you think about the population, you talked about this before about you kind of exist within a group of neurosurgical, one ST1 want-to-bees, and that they are a homogenous group with you. And so it's very, in terms of your mental health and mental well-being, everything that you've achieved is normalized.
Exactly. Yeah.
You're not like, oh, I got through medical school. That's awesome because everyone did. I've done all of these research papers. No one's bothered. And I do think so. I do a lot of coaching on like core surgical training and things like
Mhm.
that. And one of the things that I've noticed on the core surgical training applications as I've been watching them year on year is that they are not looking for the things that are going to make you a great surgeon. That is
Mhm.
not how they're trying to distinguish you from me. They
Yeah.
are trying to look at the things that separate the absolutely nth degree of candidate. They're not actually looking for the generic skills, which I find really frustrating because it used to be with teaching face to face,
Mhm.
that with teaching, that it didn't matter whether you did it online, it didn't matter whether you did it face to face.
Yeah.
Obviously, after I was very lucky. I did mine online. I was able to do it nationally because we came
Mhm.
after COVID and everyone was doing these kind of Zoom chats.
Yeah.
But now obviously they've taken it out and they've made it so to get top points, you have to do face to face, which is much harder. So you're always it's like being on a treadmill, isn't it? And especially earlier, how you were sort of talking about um, having to it's almost you were talking earlier about how once you've been out of the specialty for so long, you can no longer kind of continue. It's like it it gets harder, doesn't it? Do you think that's fair to say? Like the longer you're out of so the pressure never it's never like oh, I've been out of training for 2 years, I've now done 3 extra presentations, I've done 3 extra publications, I've
Yeah.
done all
It
this
never
time.
stops.
it's
Yeah.
it's you're still in the same level of pressure because things change.
Yeah. I'm gonna have to Google it because there's a phrase that describes specifically this. I think it's the Red Queen hypothesis, or Red Queen phenomenon, something like that. Uh, yeah, there it is, the Red Queen effect. Staying in the same place is falling behind, and it's a thing. It's a quote I think from Alice in Wonderland, where it's basically to the point of it takes all the running you can do to stay in the same place.
Yes, and the level of when Ollie and I are talking about the training, the pressure of training, it's almost like, especially for people like us who are probably quite type A, you're kind of an overachiever, all of a sudden you just are never good enough to
Nope.
continue. And I mean, I've been at this since 2018 now, and I'm still the lowest person in the room. And
Mhm.
I'm exhausted with that. I'm 36 years old. I kind of
Mhm.
thought by this point I would be able to kind of know something and do something and have a bit of gravitas about it.
Yeah.
And actually, maybe I could be a registrar next year. I could probably start working as a registrar in next spring. But I would still be, I don't know. It's very stressful, isn't it? So we've been going round and round really about some of the pressures in training. And we've been talking about the problem with getting onto training, really,
Mm.
rather than the training itself. But one of the reasons I'm kind of ground down is because once you get onto that training, the training itself is not particularly brilliant, is it? I mean, CST has been wonderful in that compared to foundation training, so I'm basically supernumerary most of the time, unless I'm on call. At the moment, I work in a lovely apartment in plastics. It's wonderful. But there's just so much other stuff. And this other stuff is the stuff that Ollie's been talking about, the fact that, I mean, he's not really mentioned it, but obviously all of the papers that you have to do, the exams, everything that you're doing extracurricular to try and, I guess, outcompete these other potential neurosurgeons, potential plastic surgeons, has to be done in your own time. No one's giving you admin time. So training itself is not like a golden egg that once you get onto training, everything's fine. And I think for me, that's where the burnout is starting to come in, because I'm kind of thinking I'm going to kill myself to get this job. And then people are going to go, oh, you know, you've got to work hard for the next 7 years full time because this is what you've been working to do. And I'm just not sure at the moment that I have that, which is why I might come out training for a bit. But let's talk about one of the most topical issues that's they're going mad. Honestly, if anyone's on Twitter, I will not call it X. I'll call it Twitter. They're absolutely going mad about this on Twitter. They're going mad about this on the On-Call room. There's a lot of controversy. It's been on this morning. It's everywhere. Let's talk about what's going on with PAs, and then also a slightly separate issue, but ACPs with skills creep. So let's finish off by talking about that. So Ollie, what's going on? What is the PA debacle? What's the controversy here?
Okay. I'm gonna do my best to be really just tactful and objective, because that I'm gonna be very
There's a lot
like
of anger, isn't there? Which
yeah.
I don't think you or I want to embody, but that is out
No.
there.
So I just want to preface everything by saying that there is a lot of anger, there is a lot of frustration, and a lot of that is justified. Some of it isn't, but that's kind of not what I'm about to get into anyway.
Yeah, and I agree, and I second that, because it must be really awful to be a PA at the moment, right?
Exactly. So I think we should just be
Mindful that people.
mindful, objective, all the rest
Yeah.
of it.
So we're talking about the profession. We're not talking about the individual people who have basically done what they were told to do, which is to sign up to an accredited training program. So the PAs themselves, I think, are not to blame for what's going on here. My sympathy does go to them, actually.
Yeah, and I'll come back to that in a minute. So what is a PA? Let's start with that. Or what is a physician associate, as they're called in the UK? So it's a story that goes back a long way. So about 20 years ago, the first pilots and trials were done. At this time, so it was a very different landscape then to what we're in now, in terms of how the workforce looks. But we were very underdoctored. We're always underdoctored, but it was worse, particularly at the junior level, at the early careers level. And in the US, a lot of the ward work or routine work in a specialty, that would typically be done by what we would call resident doctors now in the UK, is actually done by a group of people that are what are called mid-level practitioners in the US. And that includes a number of different roles, but it includes physician associates, nurse practitioners, these other groups that contribute to this tier of practice. And clearly there was whisperings in the government saying, look, can we take this role that exists in the US? It does exist in other places, but is the most evidenced and trialed and culturally accepted and all of these things. Can we take that role and deploy it into the NHS
Because
to try?
here, that model works over there, doesn't it? They're not having any controversy. This is an established role which has been is deployed, has been running for a very long time. No problems in America. Okay.
Yeah, it's a post-Vietnam thing. So it's and came out of Duke, like great medical school. You know, it's nationally deployed, very successful. There are some problems, like that, as I think there will always be between doctors and these kinds of groups, but it's just, you know, it works well on the whole.
So why the problems here?
So well, it's very multifaceted. The first is that the role wasn't regulated and hasn't been for a very long time. That's due to change in December of this year. But what that means is that scope of practice was essentially never that closely defined. And this is not specific to PAs or to any other group. But what I mean by scope of practice, for those that don't know it, is that it's the set of tasks or duties or responsibilities that someone could be reasonably expected to have. So
in my case,
yeah.
So for me as a plastic surgery trainee, my scope of practice would mean, so I'm regulated. So if I decided when I go to work next week that I wanted to, I don't know, do an amputation or something like that, that would be way beyond my scope of practice, my limitations. And I know that because that is defined in my role. And if I were a bit of a maverick and I was doing all of these kind of things, the GMC would say, you are a bad doctor, you can't do this.
Yeah.
But what you're saying is with PAs, there was never a scope defined as to what they should be able to do, nor a regulator to say to kind of oversee them.
Yes. And what that means as a consequence of that, and one of the advantages that was touted of the role, is that because that scope was not formally defined in any particularly tight way, it was seen as very flexible, and the department could take a PA, this new exciting thing, and train them to do basically whatever you want that is useful for your department. And because, unlike doctors, they would not rotate around, which we are required to do to gain our different forms of experience, I think the idea was that they would become a consistent, they would develop a lot of institutional memory. And if you wanted to train them to do a clinic, and see your post-op patients or something, similar to how you would use a specialist nurse, they could just do that year after year after year. Or if you wanted to train them to do a procedure like a lumbar puncture or whatever, they could just do that over and over and over and over, and you wouldn't have to keep retraining people to do it. Now, and as an isolated idea, that's not necessarily a problem, and I can understand why people would like that. If you said to a consultant, do you want to have to retrain someone to do this procedure every 6 months, or do you just want someone that you have to train once and then they can do it for age?
And there was an idea, was there not, that many of the foundation doctors were complaining that their job was very admin based, it was very soul destroying, that, you and I, as, foundation doctors, we should really have had the opportunity to be going to theatre, but I don't know if you, like me, I was always on the ward, I never got to theatre, which does affect me, my skills as a surgeon. I'm going to be a less good surgeon because I've had less experience.
Yeah.
I think the idea was that some of these auxiliary professionals would be brought in to do some of the roles, the routine clerking, the blood taking, to be quite ward-based in a lot of roles, to allow the F1 or F2 to, get to respiratory clinic or to go to the theatre wherever their learning was best. And I think that was part of the kind of initial kind of sell to doctors. Is that right?
Yeah, to some doctors. So it certainly, I think that placated a lot of doctors who, and if you look at the literature and what people were saying, that there was objection to this, going back years and years and years, just as there was with the introduction of other roles like advanced nurse practitioners and all of this. People are always going to argue about these things, and they probably should. We're trained in medicine to be quite skeptical, and you challenge the evidence, and you see what will give the best outcomes for patients. But the other side of all of this, and this represents what I genuinely believe, based on my interpretation of the evidence, is that part of the reason why the government was so fond of this was that it was thought to reduce locum spend on doctors, particularly at the SHO level. And because locum in the NHS in general, one of your biggest causes of spending is wages, because it's a huge employer and doctors are expensive relatively within that staff group. Locum doctors are then more expensive. And because we never had enough doctors, you were always spending lots of money on locums, especially long-term locums. So the government then said, well, can't we bring this role in and reduce that reliance on locum doctors? And that was the great appeal. And when you look at the early papers from the time and the calculations and things that were done, that is what they were very fixated on, is the idea that you could bring locum spend down. But as you say, that is not what was sold to
The
doctors and those that would be supervising. Yeah, exactly.
Where's it,
And the PAs themselves.
Where's it all gone wrong? Why are people so angry on Twitter about this?
The problem has come with, because that scope has not been locked down, it leads to all kinds of various deployments, people doing lots of different things with no governance necessarily in place or accredited training to back that up. But it creates a lot of perverse incentives. And again, I want to stress that this is not a problem with the role themselves. And it's not just a PA thing. It's, you mentioned ACPs, advanced clinical practitioners, any other group that might do similar work to what a doctor might do, or similar roles or tasks. Doctors are highly rotational, which is deemed necessary by the Royal Colleges for us to develop to become senior independent decision makers. And we usually move around, is it fair to say every 6 months, every year? Something like that.
Yeah.
Yeah. Yeah, as you say, 4 monthly for the first couple of years, because all of this is we are told is necessary in order for us to develop the breadth of experience and exposure to lots of different things. And that's the major difference. These other roles don't do that. They are.
So RPA, I get confused about this because I think because of the problems with the scope, are they at SHO level or registrar level?
This
is the issue, isn't it? Is that,
yeah.
So my understanding was that ACPs and PAs were kind of brought in to be kind of where I am, effectively like a senior SHO.
Yeah.
But we have, obviously, there've been some stories about that not being the case, which I think people are very concerned about. You don't always know what the actual truth is when you see things on Twitter.
No.
But the problem is that in some ways, no one's able to do anything wrong because the scope has not been defined.
Exactly.
That's the problem. So I don't think any trust has necessarily, it's not like allowing an SHO to, do something outrageous. We just don't know what that scope should be. And like you say, there's a lack of evidence. So there's been obviously a very high profile case about a death of a young woman, which is awful, which was in GP. And like you say, there's been no scope defined in GP as to whether PAs should see patients alone. Certainly when I was in F2, I was at the end of my F2, I think every patient I saw in GP was ran past a senior GP, which actually slows that GP down, because though I'm seeing patients, that GP is also responsible for all of my patients. So as an F2 doctor, I'm told I'm not competent to see a patient and just make a decision by myself. So in the medical profession, we have safety nets, don't we, for things. And yet, I think the PA model has sort of been launched without anyone really knowing where they should be or what they should do. And then, so that was one, that's the scope of practice aspect of it. But then we kind of come on to an issue that really affects me as a surgeon. I don't know if this has affected you whilst you were clinical, Ollie, is skills creep. And because, to touch on what you were saying, you're rotational, I'm rotational. I'll be very honest, no one cares about me. I come in for 4 months. When I was in Gen Surg, there's like 20 million consultants. So I rock into your theatre on Monday. You don't know me. I'm a CT2. You couldn't pronounce my name right. and I'm off again, and you'll see me maybe in 7 weeks' time, especially because I'm less than full time. You don't owe me anything, you don't know me. And that's, I think, common for many of us, that we no one's invested in us because we're transient.
Yeah, exactly.
Is that fair to say? But then what you have is, and this is natural, I understand it, is that you have a PA or an ACP who's in the department, they become your friends, they're on a first name basis with all of the consultants. So they end up being more competent than us in certain procedures because they're getting sometimes the preferential training. And so what's happened is where we were supposed to have, F1s, F2s being allowed to go off the ward, they're now, from what I have read, are complaining that they are on the ward doing the ward job, whilst some of the auxiliary professionals are doing registrar kind of level things. From my own experience, I have been had to share a stoma with a surgical first assist who was, I think, less than a year training. I'm not don't quote me on that, not sure. I've had SCPs refuse to scrub in to assist me because she said either she does the whole procedure or nothing at all. She would not even tolerate me. It was my list. I allocated it. I was not random. She would not tolerate me being in the list with her. So literally a level of, obviously this talk is about the pressures of training, and this is one of the things that, especially for surgeons, I think, because I think if you're on a medical ward, any help is brilliant, and they're doing, certainly I think, less procedures than we are, although I know they complain about lumbar punctures and chest and clinics like that. But certainly for you and I, we want to be in theatre all the time. We want to be leading and doing and learning and being corrected. And so certainly for me, in terms of the pressures of training, a year ago when I was in Gen Surg, I was almost ready to throw in the towel, to be honest, because I thought, so what I was told was that I had to spend £50,000 at medical school. I had to put myself through med school and all of the stress and hard work, had to go through foundation so that I could stand there and do that stoma. And then all of a sudden, I'm not allowed to do the stoma because of this. And for me, that was very draining. And so that has been, my experience. And that's, honestly, my first job was as in cardiac surgery. They had the best and baddest ACPs, and there's like a lot to be said about the ACP. They've often nurses, they've sometimes been like cardiac nurses for 15 years, they're put in central lines, and they're actually really brilliant for the F1 because if you've ever done a surgical job, all of your regs are in theatre. So there's someone there who's not transient, who's able to show you what the process is and help you and assist you. And I wouldn't have got through that first job without some amazing ACPs. And they train for 4 years, those guys. They really know their stuff. So there's a lot of positives to be said, especially about the ACP role, which I don't lump with the PA role at all, because you've got nursing training, usually working as a nurse, and then 4 years of ACP training. So you've got a really substantial body of training for an ACP.
Sure.
PA is different, isn't it? Because they're only training for 2 years.
Yeah. And it's complicated and nuanced. And there's a lot. There's a huge amount that you've just said there. Most PAs will have done an undergraduate degree before they then go and do the 2-year PA program. There are 4-year undergraduate programs for it now. But really, for me, to crystallize out everything that you've just said, it's about we're trying to we've got two competing non-melding things here. One is about standards, and those standards are set by the Royal Colleges in each specialty and regulated then by the GMC. So on the one hand, you have this medical training and regulating system that says, Lauren-Jane, if you want to be on that stoma list and learning to be a surgeon, you need to have done XYZ, so 5 years of medical school, 2 years of highly rotational foundation where you're moving around, you've got no stability, but you've got to see all of these different things, doing nights, weekends, on calls, knowing things to a very high level, and doing all of these exams and papers and courses and all the rest of it, just to get to the point where you can watch or scrub in on that stoma list.
Yeah.
And those standards are rigidly upheld. There is no flexibility, no understanding, no nothing. It's either you're at that standard or you're not. And if you're not, get out. Like, you have no value in the system whatsoever. But in order to meet work demand and volume of stuff that needs to be done, these same standards then do not apply to other roles. So it could be a PA, it could be an ACP, it could be an SCP, whatever, who are not part of this whole complex and not overseen by it and are not held to the same very rigid, very inflexible standards. And then the transience thing, as you say, is another problem where if you have someone who is longer term in a department and has that institutional memory, it is obviously going to generate an incentive for them to be trained, because the person, as you say, is going to be gone in 4 months, in 6 months. So all of this is a balance between the arbitrary set of standards that the training and regulation complex for doctors decides are necessary for doctors to progress, which are very high standard, very inflexible, that are not then applied to other groups. And one would think that the scope of any other role doing those same activities would be tied to their relative level of training. So a PA might have done 2 years of a medical model degree, as it's often described. I still don't really know what that means, but that is the way that the courses are described, which compared to the education that a medical student receives is obviously like half or less than half if you accept that both are full-time courses. And then the doctor will do 2 years of rotating on top of that, including nights and weekends. And so therefore you would expect the scope of that doctor to be much wider and much deeper, simply based on their experience. But on the ground, that's not necessarily what you see. And I think that is very disheartening when doctors then see that and say, well, I was told I had to do all of these, ridiculous things and have a CV as long as my arm and all of these things to get anywhere near the point where I can scrub in to do that stoma. Yet other people essentially appear to have been fast-tracked there with much less training, simply because that is what the department has decided it wants to do. And that moral injustice, putting anything about training, etc., to one side, that's a massive moral injury to doctors. And I think that is where a lot of the anger comes from, is that the perception is that doctors are being held to a much, much higher standard than these other groups by doctors, I should point out. But those same standards are not applied elsewhere, because if we did, the workforce would just collapse, like hospitals would collapse immediately. And that's what we're trying to balance.
So, I mean, I think the common thread between what we spoke about earlier is basically like it's like fighting for air, fighting for training, effectively.
Yeah.
You're having to fight through med school, you're having to fight through foundation, and then you're having to fight to get into training, which is where we are. And then even when you're in training, you're now fighting in constant competition with not only with your peers who are also going for the same job as you, but also with all of these auxiliary professionals. And so I guess to kind of summarize and end this video, we've been talking about, some of the things that I certainly that I wish I'd known before when I started considering this career was just I guess how much the competition is, because obviously people always say it's really competitive to get into medical school, don't they? But actually this level of competition is ongoing, isn't it? And it's
Yeah. Yeah. It never stops. And you get better. I was saying to you before we started that myself and my wife, we've just applied for what are called academic clinical fellowships, and these are a version of specialty training. Um, like you could become a plastic surgeon or a neurosurgeon or whatever, but you get dedicated, protected research time while being expected to meet the same standards as all of your peers who don't do that job. And by the time you get to applying for an academic version of a clinical specialty, you're talking about the like top few percent of doctors of that level. So getting a neurosurgery number is hard. It's really hard. Getting an academic clinical fellow neurosurgery post is like, another step up. And in order to do this, you put together this like 20 or 30 page application, which is a summary of like everything that you've ever done, all of your electives, your prizes, your papers, your like posters. You've spent thousands and thousands of pounds on additional degrees and doing all of this stuff. And there is a moment where you look at it on paper and you're like, this is it. This is me. This is everything. And what do I have to show for it? Like, I'm not, and statistically, I won't be offered a job, despite the fact that even like among the population, you've achieved things that are crazy. Among your own peers, you might have achieved things that are crazy, but all of the unbelievable effort and the time and the sacrifice and the money and time you could have been spending with friends and family, but you were sacrificing your youth essentially to do all of this stuff. You're still in the same place. And it's that, as you say, constantly fighting and fighting and fighting just for a chance to progress. And that progression is not guaranteed. So you have to keep fighting.
And it is really hard. And I think, whoever you are watching this, I'm sure that like Ollie and I, you've achieved massive things and you've come a massive way. And I think the hope for the future is that, I hope that we kind of rise up for each other. And as we go forward, we kind of try and fix some of these problems. And that's one of the reasons why I wanted to make this video, because if we talk about these problems, we can unite together and try and make sure that for the students that come beneath us, that when we're consultants, that we are advocating for each other, that we are standing up for each other. And that we always remember that we are one community. Like no one understands how hard medical school was apart from each other. You can't explain to anyone who's not a doctor how hard foundation was, how nervous you were to get your foundation ranking. And so I hope that we can move forward and create something positive. So thank you so much, Ollie, for coming and talking with me about this. I always love talking to Ollie, so I'll think about something else that we can chat about and I'll make sure I grab him back. But thank you so much to Ollie and thank you for watching.